Welcome to This Explainer. Today, we're diving deep into one of the most fundamental and, frankly, one of the most important concepts in medicine, acid-base balance. We're going to break it all down using material from a clinical biochemistry lecture designed for second-year medical students.
So, here's how we're going to tackle this. We're going to build our understanding from the ground up. We'll start with the basics of pH and buffers, then look at the body's major defense systems. After that, we'll explore what happens when things go wrong, and finally, we'll put it all into practice and solve some real clinical cases.
All right, let's dive right in. First things first, we need to appreciate the incredibly precise environment our body is constantly fighting to maintain. It is a true state of balance.
So, take a look at these numbers. The pH of our arterial plasma is meticulously controlled, right at 7.40. Now that corresponds to a hydrogen ion concentration of just 40 nanomoles per liter. That is an incredibly tiny amount. The body just cannot tolerate much deviation from this very narrow range of 7.35 to 7.43. If we stray too far, it can be catastrophic for ourselves, affecting everything from how our enzymes work to the very structure of our proteins.
So what happens when some extra acid suddenly shows up? Well, that's where our first line of defense kicks in. The buffer systems. You can think of buffers like sponges, just immediately soaking up those excess hydrogen ions. The main buffer outside of our cells in the extracellular fluid is bicarbonate, and it's perfect for the job because there's tons of it and it's tightly regulated by the body. Meanwhile, inside our cells, other buffers like phosphate, proteins, and even the hemoglobin in our red blood cells are all doing their part in this initial cleanup.
Okay, but buffering is really just a temporary fix. It mops up the acid, but the acid is still in the body. To get rid of it for good, two major players have to step up to the plate: the lungs and the kidneys.
Now, these two organs work on completely different timelines. The lungs, they're the rapid response team. If our blood gets too acidic, our brain says breathe faster, and we start blowing off more CO2 to lower the acid level. If we're too alkaline, we slow our breathing down. But there's a limit to this, right? You can only slow your breathing so much before you run low on oxygen. The kidneys, on the other hand, they're the slow, heavy hitters. They are our third and most powerful line of defense. They aren't fast. It takes them days to make a big change. But they are the ones that can ultimately fix the problem by directly kicking acid out of the body.
So how exactly do the kidneys pull this off? Well, it's a pretty clever bit of chemistry. Inside the kidney tubules, they use a two-pronged attack. First, they combine hydrogen ions with phosphate, package it up as dihydrogen phosphate, and send it out in the urine. Second, they generate ammonia, which acts like a trap for even more hydrogen ions, which then get excreted as ammonium. This whole system is brilliant because it stops our urine from becoming so acidic that the process would grind to a halt. It allows us to get rid of a whole lot of acid, about 1 millimole per kilogram of body weight every single day.
Okay, so we've seen the systems that keep everything in perfect balance. But what happens when they get overwhelmed? Well, that's when we get into disorders. We're going to start with the metabolic side of things, which you'll see is primarily all about changes in bicarbonate.
In metabolic acidosis, the core problem is a drop in bicarbonate. Your body knows this is bad, and the lungs immediately jump into action to compensate by making you breathe faster and deeper to blow off CO2. This rapid, deep breathing is a classic clinical sign. We call it Kussmaul's respiration, and when you see it, it's a huge red flag that something is seriously wrong. Now, this leads us to a critical diagnostic question. Our body has to maintain electrical neutrality at all times. So if we lose a negative ion, an anion, like bicarbonate, another negative ion has to step in to take its place. The question for us as clinicians is, which one is it? The answer is the key to finding the cause.
And to answer that question, we use a fantastic tool called the anion gap. It's essentially a calculation that helps us figure out if there's a hidden acid lurking in the blood. If the anion gap is normal, it just means that chloride has stepped in to replace the lost bicarbonate. You see this in conditions like certain kidney problems or from losing bicarbonate through the gut. But if the anion gap is raised, that's the smoking gun. It tells us that some other unmeasured anion, like lactate from an infection or ketones from diabetic ketoacidosis, is the real culprit.
And to remember the major causes of a high anion gap metabolic acidosis, there's this classic mnemonic: mud piles. It's super handy.
It covers a whole range of nasty things, like methanol poisoning, uremia from renal failure, diabetic ketoacidosis, lactate buildup, and even toxins like ethylene glycol or an overdose of salicylates, which is just aspirin.
Now, on the complete flip side, we have metabolic alkalosis. This is where your plasma bicarbonate concentration is too high. The classic cause is losing a ton of hydrogen ions from stomach acid during severe vomiting. It can also be triggered by a serious potassium deficiency or, much more rarely, by someone actually ingesting a large amount of an alkali substance.
Let's move to the other side of the coin. That was the metabolic side. Now let's look at respiratory disorders, where the primary problem, as you might guess, lies with carbon dioxide.
So respiratory acidosis happens when you can't breathe out enough CO2 and it starts to build up. This can be acute from something like choking or a sedative overdose, or it can be chronic, like in patients with COPD. In those long-term cases, the kidneys will eventually compensate by holding on to more bicarbonate. Respiratory alkalosis is the exact opposite. It's caused by breathing too fast and blowing off too much CO2. It's much less common, and the classic cause is a panic attack.
So, we have all this theory, but in a real patient who's sick in front of you, how do you actually figure out which one of these is happening? Well, it all starts with one very specific, very important blood test.
The key to unlocking this whole mystery is the arterial blood gas, or ABG. This test is our window into the patient's acid-base status. But here's the thing, getting an accurate result is all about meticulous technique. You have to use a special heparinized syringe, get every single air bubble out, and then you have to get that sample to the lab for analysis within 15 minutes. And you never, ever look at an ABG in isolation. It has to be interpreted alongside other lab results like kidney function, electrolytes, and glucose to get the full picture.
Now, this is where things get really interesting. Sometimes a patient has more than one primary acid-base problem going on at the same time. We call these mixed disorders, and they can be really tricky because the different processes can actually cancel each other out, making the pH look deceptively normal. A classic example is an aspirin overdose. It directly stimulates the brain to cause hyperventilation, a respiratory alkalosis, but it also causes a severe metabolic acidosis. It's a real clinical puzzle.
All right, enough theory. Let's apply everything we've just learned to some real-world scenarios. I'm going to give you the data from a few cases, and we'll walk through the diagnosis together.
Okay, case 1. We have a 65-year-old man with COPD. First, look at the pH. It's 7.10. That's low, so we know we have an acidosis. Next, what's causing it? Look at the PCO2. It's sky high at 11.5, so this is a respiratory acidosis. But hang on, look at the bicarbonate. It's also high at 32. What does that tell us? That tells us his kidneys have been working overtime retaining bicarbonate to try and fight against that high CO2. This is a perfect picture of a compensated respiratory acidosis.
Here we have a 17-year-old boy. His pH is 7.49. That's high, so we have an alkalosis. Now look at the PCO2. It's low at 3.2, and the bicarbonate is normal. A low PCO2 is driving the pH up. This is a classic textbook picture of an acute respiratory alkalosis, almost certainly from hyperventilating during a panic attack. And the tingling in his fingers? That's caused by a temporary drop in the active ionized calcium in his blood because of the alkalosis.
Next up, a 48-year-old man who has been vomiting profusely. The pH is high at 7.50, and the bicarbonate is also high at 29. A high bicarbonate causing a high pH? That's our definition of a metabolic alkalosis. You can see his PCO2 is at the high end of normal, which means his lungs are trying to compensate by breathing a bit slower to hold on to some acid. This is all being caused by the massive loss of stomach acid from all that vomiting.
Okay, our final case, a 20-year-old man who is very sick with a fever and low blood pressure, likely sepsis. His pH is very low, 7.13, and his bicarbonate is also low. That points straight to a metabolic acidosis. But here's the twist. What should his lungs be doing? They should be compensating by breathing like crazy to blow off CO2. But look at his PCO2. It's high. This is a huge, huge red flag. It tells us that he not only has a severe metabolic acidosis, but his respiratory system is also failing. This is a mixed disorder, and it's incredibly dangerous. You see, understanding these numbers, being able to interpret the blood gas and spotting the compensation, that's absolutely vital. It's the first step, but it's just the first step. The ultimate goal, the true art of medicine, is to connect these patterns back to the patient in front of you and treat the root cause. Because restoring order isn't just about fixing the numbers, it's about treating the sepsis, giving the antidote for the poisoning, or managing the diabetes. That is what truly makes the difference.